Well, thank you, everybody. I made it in last night before all the crazy rain in Houston and Austin. And I also just got back from Japan, where we had a big Japanese Society of Hematology meeting, and it was fantastic. I am a little jet-lagged. However, my original slides I had made for this got corrupted. This is a story of my life. And so these are slides that are a little bit more in depth in terms of data. The first two slides I'm going to spend the most time on. The last slide I'm going to spend a lot of time on. Everything in between, I'm just going to show you to say this is all the research we're doing. So the hope is real. CAR T is the best thing that we've had to come into myeloma, in my opinion. I also do CAR T research, so that's my COI. And it's the reason I didn't quit during COVID. So, COVID was crazy for all of us, but in the medical center, and when you're in the medicine field and you have patients who are really vulnerable, an infection like that just causes chaos. And so again, because my patients were doing so well with CAR T, I knew that this was something completely different. And again, a personal reason as to why I do so much research in CAR T, because it really does make a huge difference for my patients. Okay, so with that, hopefully. There we go, if I can figure out how to use this. So CAR T unveiled. So again, my first two slides are really just gonna talk about what is CAR, what is T cells, and talk about the basics, and then even the logistics about the basics of CAR T. It is very different than every other drug we ever use for myeloma. It's personalized. It's probably the most personalized treatment we have for myeloma right now. There's good and bad to that. The good is that it's really your cells, so there's less toxicity compared to using somebody else's cells, but it also means it's high maintenance. We have to do a lot of things to make those cells, and a lot of things can go wrong. And so I'll talk a little bit about that. And then after that, the second section really is going to be on some of the data of how responses and how long people respond. And then all the new treatments now. These were the first generation CAR Ts that we have, and now, of course, there's a lot of interest to say, how can we actually make patients do better in terms of hopefully a cure? We talk about cure for the first time in relapsed refractory myeloma because of some of our CAR Ts, which I'll talk about as well. Okay, so what is chimeric antigen receptor, or CAR? So T cells, I'll start with T cells. In our blood reports, right, the white blood WBCs, white blood cells, it says neutrophils. We're always worried about your neutrophils. We talk about, our treatments causing the neutrophils to go down, or ANC, we sometimes say, and we give you shots to help bring that up if they're too low, so make sure you don't get infections. Neutrophils help with bacterial infections. But right under that, you'll see something called lymphocytes. These are our normal cells in our body that usually fight viruses and fungus. And part of that, T cells are one type of lymphocyte. And so T cells are the one white blood cell in our body that actually, when they're born in our body, when they're made, they have a receptor already inside there called a TCR. That receptor is like a night vision for them. So it's crazy how our bodies are made, but T cells, each one's different. So let's say you get exposed to the flu or something else, they're gonna have a T cell that actually goes after that flu. Once it finds it, it starts killing it, and it sends these cytokines out. Cytokines are important with CAR T, so that's why I'm saying this. These cytokines are messages, these enzymes that go throughout your body that have other white blood cells then help fight that pathogen, that virus that we don't want in our body. And so what we're able to do now, this is 40 years of research. People have tried this for a long time, but finally in the last 10 to 15 years, we figured out how to take these T cells out of the body and actually put in a new receptor, so the chimeric antigen receptor. Chimera just means the way that these receptors are made. Some are fully human, some are not. And so again, it's just a scientific term, but we can put a new receptor in there into that T cell and then grow the T cell. And the receptor, instead of a virus or something else, it actually is to something that is on your myeloma cell, so a flag on the myeloma cells. So on the right side, that's just a picture of all the different flags we found in myeloma. So Dr. Matsui talked a little bit about different kinds of myeloma, high risk versus standard risk. There's genetic changes in each of these myeloma cells that make it work a little bit differently, and why that myeloma cell became a myeloma cell. And a lot of our other treatments go after those pathways inside the cell, With CAR Ts and immunotherapies, we actually are looking at the outside of the cell. So how can this T cell that now has night vision can find that myeloma and start killing it, and then again, release those cytokines to get more white blood cells to come help fight that myeloma. And so really, it's just, we're using your own immune system, putting a new receptor so it knows where to go. So we're redirecting them to the myeloma instead of viruses and things like that. And again, in CAR T, unlike bispecifics, where you'll hear a little bit about later, we're actually doing it actively. We're taking the T cells out, putting this in, and then we grow them. So you actually get millions of cells instead of just the cells that we took out. Okay, so hopefully that made a little bit of sense. So what is the actual process? So in the middle, you see number one, patient eligibility. Most patients, I would say, are eligible for CAR T. Not everybody, and it's when you're eligible. It's not that you're always going to be eligible. So if someone has really bad myeloma that I need to treat right away, because of how long this takes, it takes about a couple of months to get patients ready to go, get insurance approval, get your cells collected. It takes about 4 to 6 weeks to make the cells right now. Then you come back to actually get 3 days of chemo. This is called lymphodepletion chemo. Again, your T cells, you still have them in your body. The ones we took out, and we're making them. But you still have T cells that are going around. And if I gave you those CAR Ts with the new receptor in there, without doing anything else, which we've tried, the T cells already in your body are going to find that CAR, that new receptor, and say, you're not supposed to be here, and they're going to kill off all the CARs we just made, right? So we don't want that. So what happens is you get 3 days of chemo called lymphodepletion that knocks your immune system down just enough for a couple of weeks so that when we give you the CAR T cells a couple days later, they can go in, find the myeloma, kill it, and then when your immune system comes back, it actually will take out some of those CAR T cells. We don't need them forever, and we don't want them forever. We'll talk a little bit about toxicity. And so we want to use your immune system and make sure that the CAR Ts work, but eventually we gotta get rid of those CARs down the road. So again, but it takes 4 to 6 weeks to make these. So what happens during those 4 to 6 weeks? For most patients, if there's any myeloma around, we give you something called bridging therapy. So you're getting some kind of, either daratumumab or isatuximab, pomalidomide, some kind of regimen that's helping to help knock that myeloma down and keep it down while we're making these cells. So one of the biggest issues right now we have is my patients who need CAR T, I have to make sure that they're going to get through the next 2 months and actually get their cell infusion. So that's what I meant by most patients are eligible, but it's the timing. And so sometimes, if I have a patient that came in and said they have a lot of myeloma right there and then in front of me, I might start something different, but my goal is to get the T cells collected, get everything set up, then do the bridging, then come back and do the CAR T. So, it's not that you're not eligible, it's more of when are you eligible is really, really important. The second part, the apheresis, leukapheresis, that's the part where we actually take the cells out. So for anyone who's had a stem cell transplant, you'll remember you had 4 days of shots that help your stem cells come out. This is different. This is very different than transplant. In transplant, we're trying to take stem cells because the big dose of chemo we give, called melphalan, really kills everything, the myeloma cells, but it also kills all the other cells in your bone marrow. So we have to give you shots to actually get the stem cells from your bone marrow out into the blood and then collect it. This is very different. Lymphocytes, T cells, are already in your blood. And remember here, it's the lymphocytes, it's the white blood cells that are actually going to kill your myeloma, not chemo. So it's a little bit different, even though we have similar things that we do. So apheresis is where they actually put a line in, a central line, put you on a machine like a dialysis machine, and then collect your cells for about 2 to 3 hours for most patients. Take that line out, you're done, you go back home, you get your bridging therapy with your doctors at home. While we're waiting for those 4 to 6 weeks, we actually put these cells on a plane and they go to a lab where they actually make them and grow them in sterile conditions, et cetera. So that's the apheresis. Thankfully, in CAR T, just takes a day, not like it does about a week that it takes for a transplant. And as we talked about, manufacturing. So in the old days, when we first had CAR T, I had some patients' cells that got stuck on a plane that never took off. You can imagine that patient was very upset. I had to bring them back and do the whole collection thing again. We've had patients where the cells weren't great, so the actual product didn't end up being a product that we wanted to use or could use. So there are such things as manufacturing failure, or patients who have out-of-spec cells, which is getting better and better. We're all learning and we're all improving, so that has improved a lot even in just the last year. But that can happen. And again, why it's so important that we time this correctly. If someone just had transplant, or they had certain chemotherapies or certain therapies that kill your T cells, right? So some of the other treatments we talk about do knock your T cells down. And if we try to collect your T cells right after that, you can imagine those T cells aren't very good. And then we put them through all of this, and what we get at the end is not very good. So there's a lot of timing in terms of what treatment you just had, how long do we have to hold it. We're trying to figure out, we have some other great therapies in myeloma that can activate your T cells, so should we be giving some of those before we collect? Again, we don't have all the answers, but that's some of the places where we're trying to figure out how do we make sure no one has manufacturing fails. And then we talked about the bridging therapy, we talked about the lymphodepletion, and then when you come back, again, you get those 3 days of chemo, you get the cells. For us, we can do a lot of it outpatient. When these cells go in, they are going in pretty fast, and they're gonna find your myeloma. Different CAR Ts, and I'll show you the 2 that we have approved, work differently, and it's because they're made differently. And so one of the CAR Ts, called ide-cel, you actually get 450 million cells, you go in, and they start finding that myeloma quickly, and most of my patients get fevers, because these are T cells, just like when you fight the flu, right, or fight a viral infection, what are the symptoms you get? You get shivers, you get fevers, you get, people can feel like they got hit by a truck, the fatigue, the muscle aches. Those are the type of side effects we're watching out for. And if you had really good bridging therapy that we talked about to knock that myeloma down, if there's less myeloma, those T cells don't have as much killing to do, right? So there's not as much inflammation that happens, and so people have less symptoms. So again, with ide-cel, those cells go in, they find that myeloma. Most of my patients get fevers within the first 1 to 3 days. We treat it. We have lots of things that can help knock those cytokines down. Tylenol, those are usually the things we use, but we also have something called tocilizumab that doesn't affect the T cells. They still do what they need to do, but we can knock those messages down that they're giving the other white blood cells to calm down, and people feel a lot better. And then most of my patients are in the hospital anywhere from 4 to 7 days, and then the rest is all outpatient. With cilta-cel, it's a different CAR T, and so it takes a little bit longer. We only give 50 million cells. They go slowly into your blood, find the myeloma, then they start growing. So most people don't have fevers till the 2nd week. And again, it's because we make these CAR Ts a little bit differently. So these are the 2 CAR Ts that are approved, so ide-cel and cilta-cel. It's like Legos. The other thing I was going to be is an engineer, and so Legos are cool to me. There's so many different parts to what that CAR is. I'm not going to go into detail, but there are different ways you can make it, and it can help make the T cells work faster. So sometimes if you want the T cell to go in and just start going crazy and work really fast, you can do that. There's other things you can put in that makes them a little bit slower. There's different what we call antigens. Antigens are the flags that are on the myeloma. So these 2 CAR Ts go after something called BCMA, B-cell maturation antigen. That's the flag that we're trying to use to go after myeloma. And any antigen we try to find, we want to make sure it's not on normal cells, right? Because obviously, if these T cells are on something that's on normal cells, they're going to go kill that too or cause toxicity. So this was the first target. It's been worked on for over 30 years, but it was the first target we found that not only is on most patients' myeloma, over 95%, which is huge, we need that, but then it's also not on other major cells where we worry about going to the heart, going to the brain, going somewhere else. So in the past, there are a lot of targets we tried to use, but unfortunately, those were targets that were on other organs and caused a lot of toxicity. So again, why it took this long to get here is because of this. We had to find the perfect target, had to figure out how to make those T cells work, but not too well, where it caused a lot of toxicity. Okay, so what about the results of all of these? The next few slides, I'm going to go a little bit faster just so I can have time about at the end. So CARTITUDE-1, this was one of the first studies done for relapsed refractory patients with cilta-cel. And why this is so important is just in June, we got the update of patients on average, all patients that already had 5 years of follow-up or longer. This is the first time we've used the word cure for relapsed refractory myeloma. So that thing that I've circled is called a plateau. That 33%, so a third of the patients on this study, 5 years out from their CAR T, still in remission and have no myeloma, not on treatment. So to have no treatment for 5 years, These patients had 6 lines of therapy already, so they pretty much had everything else we ever talk about. So this was the first trial that was done, and so to have this, we never had this before, to have this, I can tell my lymphoma and my leukemia doctors, hey, we have a therapy that could potentially cure patients too, which is huge. It makes a big difference in terms of saying that I can have survivorship clinic now. I can do all these things for myeloma that other cancers have gotten to do. And this is our first look at this. So now what our goal is, how do we make that cure fraction higher, right? Now, for me, 5 years is great, but I want more than 5 years. I want forever, and I know all my patients want forever too, right? So again, I can't promise that this is forever for all those patients. I hope it is. But we still think that people can relapse. But the big difference is now we know how to get here, so how do we get it better? And then how do we keep it forever? So those are really our goals at this point. I'm not going to go into the details of this, but again, what T cells we get out from you first that we put in really does matter. So you want less myeloma. So this thing is saying that effector cells, which are the T cells, the more of those there are and the less myeloma there is, better patients do, as well as the type of T cells. So if T cells look younger and healthier, they're going to do a lot better than if they look really, ragged and exhausted, which is what I feel like. I feel like an exhausted T cell most days. But you want that better, healthier T cell. And you want more T cells compared to myeloma. And why that's important is in this study, this CARTITUDE-1 study, we had patients with high risk. We had patients with the cytogenetics that were high risk. We had patients that had extramedullary disease, meaning that the myeloma had learned how to come out of the bone marrow and out of the bones. And there are people having tumors in their livers and other places. They didn't necessarily do worse. Some of those patients got that 5 years or longer. It was the fact that they had less myeloma going in, and it was the fact that their T cells were better. So again, this high-risk stuff is really important, but some of these types of therapies might be able to circumvent that if we figure out how to actually do it properly, right? Which is, I think, really exciting for our patients with high-risk disease. There's another CAR T, the third one, that's coming out that we're going to have a big presentation, hopefully in the next 3 to 6 months at some point to talk more about it, but there is some data already. It works a little differently. The CAR part, that receptor, is made very differently than the other two. And so far, again, we have some data that I'll show you. Response rates, 97%, which is similar to what cilta-cel was, 98%. So meaning all the patients that got on, 98% of them actually had a response, or 97% of them had a response. And in that blue, you see the CR rates, which is meaning we got all the myeloma down to its lowest, and again, 68%. So no other therapy as a single agent has done this in relapsed refractory myeloma except CAR Ts. So all our CAR Ts keep showing things like this, which is great. And then safety-wise, this is important. Here in this study for anito-cel, which is again the third CAR T, CRS, cytokine release syndrome, that's the fevers. That's where your T cells are going and causing the fevers initially. If you have a higher level of CRS, let's say you had more myeloma, or your T cells just happen to be, my T cells are very reactive. I get a fever even like with, my allergies. But if you have reactive T cells or you had a lot of myeloma, and these T cells have to work harder, they grow. Each time they kill, they're growing as well. And again, they call more white blood cells, so there's more inflammation. If you end up with more inflammation, their oxygen levels can go down, so they might need oxygen. Their blood pressure can go down, so they might need some fluids, things like that. And if it gets really bad, where we call it grade 3 or 4. So grade 1, it's low grade, means you just had fevers. Grade 2, you might need a little oxygen, you might need a fluids. Grade 3 or 4 is there's so much inflammation, patients have to go to the ICU, and we have to give them extra medications to help them through that part. Eventually gets better, but we don't want grade 3, 4. We like to have patients in that grade 1 or less. And so here in this study, that's all they had was grade 1, maybe a small percent, grade 5% or less, 15% grade 2. Same thing with our other CAR Ts in myeloma. 90% of our patients will get fevers for the most part, but most people end up having grade 1. We give them some Tylenol, we give them some Toci, they do great, we get them back out, right? But there are some patients who can get to that grade 3, 4, and so we just have to watch you really closely. Those are the main reasons you have to come in to see us and stay with us for a little while to make sure all that stuff is gone before you go back home. So again, the nice thing here is we have minimal. There's another thing called ICANS, or neurotoxicity, which all CAR Ts can cause. So now we're looking at when these cells go in, not only do they cause inflammation with fevers and those types of things, it can actually cause some issues with your memory. It can cause confusion, almost like delirium that we talk about when patients are in the hospital sometimes. There's different mechanisms why that can happen. We see it a lot more with lymphoma CAR Ts than we do with myeloma. But again, sometimes it's just some of my older patients. My oldest patients I've gotten CAR T is 90, so that is not a restriction. Age is not a restriction. It's more of your physical well-being and, again, how your myeloma is doing. But when older people get fevers, they can get a little confused just from the fever itself. So we think that in myeloma, it's more related to the CRS than true ICANS. So again, thankfully, we don't see it very often. If we do, we give some steroids. We hate those steroids. But here, the steroids are good. It helps decrease the inflammation down, and patients turn around pretty quickly. So again, TOSI usually works within 30 minutes. My patients, if they're having a lot of fever and just not feeling well, usually an hour after, they're like, oh my gosh, I feel so much better. Can you give me another dose of that? So these medications work really fast compared to what we think about with transplant, for instance, where it takes a few weeks before you start feeling better. So then the question comes up. So we have KARMA are the ide-cel studies, and CARTITUDE are the cilta-cel studies. And these were our first randomized phase 3, meaning that patients got either a CAR T, or they got a standard of care. So things that we had, again, like daratumumab-based, or elotuzumab, or carfilzomib, all the other options we had. And both studies show that the CAR T worked much better than any of those standard of care options by significance. So again, both of these studies told us, hey, these CAR Ts really work better than some of the options we have in early relapse, which then helped get the approval. So initially in 2021, both of these CAR Ts were approved in 5th line, meaning you had to relapse 4 times before you could get a CAR T. That's hard for a lot of patients, especially if you have high-risk disease, to get you through 4 lines of therapy and then have your T cells healthy enough to collect and get you to a CAR T. They didn't have enough slots at the time either because they're just learning how to do it. Different world now. Now this is approved in 2nd line for cilta-cel and 3rd line for ide-cel. So now I have more time. When patients come to me, I know I have time to get everything ready, and I don't have to rush and say, if your myeloma blows up, I don't know what I'm going to do, right? And I have other options like carfilzomib or daratumumab or Pomalyst or these other therapies that can help temper it until I can get you to the CAR T. So going earlier logistically helps, but there's going to be this slide that shows that it looks like it works better as well. So in the myeloma community, this question came up that if cilta-cel does so well in 6th line, do we really need to go earlier? Can we just wait till the end and then use it where we know it works so well? First of all, it worked for a third of a patient, 33% of patients that got 5 years, right? Everybody else still relapsed before that. An amazing therapy, but we want more people to get that longer-term remission. And here, they put the curves of the CARTITUDE-4, which was early line, so people who got CAR T in 2nd or 3rd or 4th line. Most of these patients got it in 2nd line, with what happens when you get it in late line. And again, both curves, that red at the top is showing us that overall survival, people are living longer when they get it earlier compared to what we see in the late line, as well as progression-free. And progression-free means how long is that myeloma controlled without the therapy, and they're still doing well. And again, it was still better for patients that were on CARTITUDE-4. We don't have the 5-year data yet for CARTITUDE-4 because it was just done in the last few years. But I do think we're going to see that cure fraction again, for at least for the 5-year cure fraction, being higher than what it was for CARTITUDE-1. So 2 reasons why I tell my patients to go to CAR T, at least by 3rd line, is just one of this, I think you actually are going to respond better. And logistically, you're more likely to actually get to the CAR T and have cells that are manufactured, et cetera. So here, I think this just shows us that when you have really good therapies, they're going to work better when you go earlier. So then the question comes out, which is the best therapy to go at the front? So now the studies that are being done that we don't have data for are against transplant. So in 1st line, instead of doing transplant, can you do a CAR T instead? Or for people who don't go to transplant, can we do consolidation with the CAR T after their induction therapy? So we'll see. We need some more long-term data for that before they present it. But when we see it, that could be the first time we actually take over transplant, which has been with us for over 40 years. So, I hope so. I think the other important part, though, is really toxicity. So we talked about the short-term toxicity. I don't worry about CRS or ICANS for the majority of my patients because, again, I can knock that myeloma down. If I have the cells ready, but my patient's myeloma is not treated, at the beginning, early on, I have other therapies I can use. So sometimes my patients will come in for bridging. They don't respond to that first bridging. I have my cells ready. I don't want the toxicity, so we'll actually do a different bridging first, make sure it's coming down, then do the CAR T. So I have those options now that I didn't in late line. But there are other toxicities that are later that we talk about. And again, one of the toxicities that CARTITUDE-1 had, about 7% of patients had something called delayed neurotoxicity. And this was not something that any of us knew about. We didn't really see it in the other CAR Ts and lymphoma. And it basically was where people would get something called Parkinsonianism, that these T cells would attack the nerve somehow, and it was really, really scary stuff. And this is not what we want for our patients. Our goal is you get to have your myeloma controlled, not be on any therapy, and live this great life before we ever have to treat it again. And so when we see things like that, we really worry. In CARTITUDE-4, because we were able to give better bridging, because these patients were still responding to other therapies, that risk went down to only one patient got this, and it was 0.5%. So again, that toxicity goes down when we give better bridging, and we're able to actually go earlier in the lines of treatment. So that really serious side effect we were all worried about did decrease, and that's why these graphs came up, part of it, because again, it's always a risk-benefit discussion, right? For whatever's happening for my patients, if you have a myeloma that's responding for 10 years in the front line, do we want to go to something that has a potential risk of Parkinsonianism? Again, now that we know it's 0.5%, most of my patients say yes, but there are certain side effects, I still talk to my patients about with CAR T to say, is this something really you want to do or not? And it is an individual choice. I think what Dr. Matsui is so important. My dad would say, I want everything done all the time. My mom would say, nope. Even if she has a cold, she's like, it's okay if I go. They're complete opposites. And that really matters in terms of what your philosophy of life is and what you're willing to potentially get as a side effect or not. And so again, I think really important to talk about that with your doctors. Okay, the next few slides I'm really gonna fly through, but this is just showing all the top little tabs are all the different flags we have for myeloma that we're actually doing CAR T studies for in trials. So again, BCMA was an amazing target, still is, but there's lots of other targets we found now to say, okay, what else can we go after with these T cells? So more data to come there. One of the big ones is the GPRC5D. Everything in myeloma is just alphabet number soup. This is another target that we have in myeloma. It does happen to be on your skin and nails and tongue. So with our bispecifics, you'll hear about later, we have seen some side effects where people have lost their taste and had issues with skin and other things. In the CAR T, because it's a one and done, we see it in the first month, but for most patients, we don't see it after that. So there are differences in the way you go after that target. But again, some great data that's coming out for GPRC5D. I'm not going to go into too much detail, but again, really great response rates, 91%, 87%, which is on par with what we see with our CAR Ts in general. And the other cool thing here is that now that people have had BCMA therapy, we say, well, what can we do after? If those patients that do relapse, what do we need to do? And so here, the response rate was still 79% overall response rate for patients who had prior BCMA therapy, which is really important that we have options for after. Now, we don't think you have to have a BCMA first to go to GPRC5D or the other way around. It was just timing that we found BCMA first, and that's why we do it this way right now. But in the future, we might do separately, or we might actually combine, right? So that's the other next thing, is how do we get, what happened to those patients that didn't get the 5 years, or even after 5 years, what happens that these patients do sometimes relapse? Our goal is, how do we kill every last myeloma cell? So sometimes these targets, these flags, are at different levels on different myeloma cells, and so it makes sense. Maybe we go after 2 targets, and different cells will have different levels of all of these. So again, lots of different trials that are combining different kinds of targets to go after. So hopefully we'll have more data on that soon too. There are a couple trials, one's looking at BCMA and CD19 as 2 flags. That looks really, really impressive. Another one with BCMA and GPRC5D. These are early, so we don't have a lot of data from the US yet, but we're really excited about seeing how that works. The other part of CAR T, as I told you, the logistics, this is a high maintenance therapy, so how do we make that manufacturing faster and better? And so there are lots of trials that are looking at how can I make these cells, the vein to vein time, meaning the time I did apheresis to get the cells out of your veins to the time I put the CAR T back into your vein, how can I make that less than 4 to 6 weeks? So there's different ways of actually making CAR Ts within 1 to 2 days and then putting them in and saying, okay, let's give it time to grow inside your body and then kill the myeloma that way. The fast CAR, which was that CD19 BCMA, this is how they do it. Again, part of it is they can make the cells within 22 to 36 hours, but then you have to do quality checks. So the FDA still requires some of these checks that take a week or two. And so we're working on that too. How do we improve that part of it? And then allogeneic CARs. So now how about we use other people's cells so that they're already made, they're already in our freezers, so you don't have to do any kind of apheresis. We've had a lot of trials with this, and I was a part of a lot of these. And here, because the T cells are somebody else's, your own immune system is going to not just see the CAR, they're going to see those T cells and say, this is not one of us. So they are going to reject those. And that's been the biggest problem with our allo CARs. There's a lot of new studies with using more lymphodepletion to really knock it down. There's ways to cloak the T cells so you can hide it from your own immune system. So again, some great studies that are ongoing, but we're not quite ready with an allo CAR T because of some of these other issues with the immune system recognizing it too fast. And then the last one, this was a big deal and something that we're really excited about really early. So we don't have there's only 4 patients that they've ever treated in the world that I know of. But this is using the vector, the viral vector that makes the T cell. So how do we put the CAR into the T cell? There's a certain way, it's called a vector. What if we just give you that vector directly? Right? And figure out a way that it homes into your T cells and you grow those T cells in your body, goes and kills the cancer, and it comes back out. This is like science fiction stuff. And so there are 4 patients they treated, and they've done really well, and it looks really amazing. And there's a lot of clinical trials that in the next few years are going to pop up with this. They're not even clinical trials yet in the US with this. So this is really the latest and greatest. But again, our science is becoming so cool that we could maybe even do this as off the shelf, and I can finally beat those bispecifics. No, bispecifics are great too, but I always have to debate CAR T versus bispecifics at some of these conferences. And again, the issue's always been the manufacturing. So if we can figure out a way to do this, that would actually fix so many of the problems we have in terms of access. So you think about this, I'm at MD Anderson in a bubble, and I get that. So my patients who can come to me can get these therapies, but most other people in the US, 20% of patients who can actually get CAR T in the US get it. Everybody else doesn't have access. And then you think about the rest of the world. Something like this could change that for everybody, right? So it's really, really exciting. There are other cells. NK cells are also a different kind of lymphocyte. There's NKT cells, again, alphabet soup. So we're also learning how to use other immune cells to go after that myeloma. Still early. We don't have any active standard of care options yet, but lots of trials we're doing for it. And then the last, I think I only have, I'm probably over now, but I'll just quickly say, trials are great to get data and to get FDA approvals, right? To get therapies approved for my patients. But trials require patients to be really healthy. They have a lot of inclusion-exclusion criteria. So if someone has heart failure, or someone has kidney disease that's a little bit too much, or they have lung issues or other things, they're not eligible for these trials. And so what we have to do is once we get these treatments in the real world, put all our data together, and this is where HealthTree has been fantastic with a lot of things, and they're going to do more in the future, but we actually have all those centers in our U.S. Immunology Consortium that we've actually put so much data together. I'm not going to go over all of it, but really looking at what about my patients on dialysis? What about my patients who have had, all these other cancers and they can't go on this treatment? So we have all these different ways that we've looked at. People who have CNS myeloma, it's not very common, but that can happen. So patients aren't allowed to go on trials when they have that because we're worried about safety, and then the trial doesn't go forward. But in the real world, we can do these things. So again, all of these papers that we've put together is to learn how to do it and teach each other, but then actually improve access for our patients in other centers where they don't have as much experience. And it's been pretty phenomenal to be a part of that. And so in summary, again, I'm not going to go through all of this, but this is the first time we've talked about a functional cure in relapsed refractory myeloma. We do need to make better manufacturing, and we need to reduce toxicity. Next generation CAR T cell constructs, we're trying to combine things and improve things to maybe increase that cure fracture. We need to make it more cost effective so it's more accessible to everybody. And then the real world evidence really helps us with those rare patient populations. Again, as Dr. Matsui said, there's multiple myelomas, right? So plasma cell leukemia, high risk, standard risk, patients that are frail. How do we make this better for everybody? And then the last thing I'll end with is the FDA did recently say that patients don't have to stay for a full month anymore at the locations where they get their CAR Ts. It used to be required as something that everybody had to stay for at least 4 weeks. You couldn't drive for 8 weeks. So some of those things changed, thankfully. So now the driving restrictions, just the 2 weeks that you're getting your CAR Ts and where we see that CRS happening. However, I will say in myeloma with cilta-cel, because that CAR T the CRS happens in that second or third week, we actually tell our patients to stay a little bit longer with us just to make sure everything's good. Because I want you to go home, but I want to make sure you go home without any problems so your doctors and you aren't trying to figure out what to do. You can contact us, but at the same time, it's not the same as we're watching you very carefully and making sure everything's going well. But we are trying to get everybody home sooner so that we know that that causes a lot of problems in terms of having to move to another city if you're not near somebody that does CAR T. Costs go up. You have to have a caregiver. You guys, everybody works, and if you have to have a caregiver that's not working and watching you, that's a really hard thing to do. So again, we're finding ways to decrease all of that, but in a safe way. So everything's getting better and better for CAR T. And with that, thank you.